Hello, everybody. Welcome to another episode of the Fort Wayne Local Podcast. I'm your host, Jake McAfee. Today, we're joined by special guest, Dr. Jon Lynch. Jon, thanks for joining us.
Yeah, thanks for having me. I'm excited to be here.
Yeah, same. So before we jump into that, I just want to say, again, thank you for all the support. This has had a lot more traction than I expected. So part of 2021 is I'm going to start really looking to focus on this. I've got some big guests lined up this year, and now people are reaching out to me, which is really cool. So it'd be very helpful if you could subscribe either to YouTube at McAfee Home Group or Fort Wayne Local Podcast, and you can find that on Spotify, Apple iTunes or Apple Podcasts, or really wherever you listen to your podcast. So if you could subscribe to the podcast, that'd be very helpful and helps me get the word out there and continue to build on what I've already got. So, okay, let's jump right in. Like I said, we're here with Dr. Jon Lynch. Jon is an orthopedic surgeon with O&E. His specialty is in hip and knee replacement, specifically adult reconstructive surgery. He graduated from Dwenger in 2005, so Dwenger Mafia. IU Bloomington in 2009 and IU Med School in 2013. That's one thing I got to work on. I've had way too many IU guys on this thing, and we gotta change that.
Good thing.
So he did his orthopedic surgery residency at the Henry Ford Health System in Detroit, and then his adult reconstructive fellowship in Vanderbilt, Nashville in 2019, which was then when he joined O&E. So, Jon, today the point is, and for everyone listening out there, as people are living longer these days, with modern medicine, and I think part of the byproduct is, our bodies need to last longer, and a lot of people are living in pain, especially the baby boomer generation, not exclusively, but especially them, and that generation's really tough, and sometimes they just tough out the pain. I know my own parents kind of went through that where my dad needed surgery, but he was very reluctant. So today I kind of want to talk about, how do we know when we need surgery? What's the process like? What's rehab like? So to get it started, how do I know when it's time to at least talk to a doctor? Like when do I know?
Yeah, I mean, and it's hard for me to gauge that exactly. I think anytime you're having hip or knee pain and it gets to the point that it's bothering you in your day-to-day activities, you can't live the life that you want to live, I think that's the time to get it checked out. And, there's never a time that's too soon or too late. But I mean, there's certainly people that I see that come to my clinic and I shoot an x-ray, and I mean, it's amazing to think that this person's made it this long with the pain they've had, clearly just based off their x-ray. So, it's almost in some ways sad to see people wait that long, because it's like, gosh, they probably lost some good years of quality of life in waiting. So I don't know the exact time, but I mean, I think if you're experiencing hip or knee pain, I think it's always reasonable to start by at least telling your primary care provider that you've had pain going on, and they're usually very good at kind of beginning the process, taking an x-ray. A lot of them can do a lot of the non-operative means in terms of trying injections or physical therapy or getting you on an appropriate anti-inflammatory or other pain regimen to kind of get things started. And then if there's ever a question, or, a lot of times we'll see the patients first too, and we can do that same process. And, I think it's, if you're experiencing pain, that's what we're here for. We're here to obviously help you with that. And I think that's what makes our profession so rewarding, and our ability to help people with that. So,
Okay. So if I'm hearing you correctly, you don't always just jump right into surgery. Sometimes you'll try some, less invasive or less intense options, kind of see where that gets you. And then if that's not getting better, then sometimes surgery is the next step.
Absolutely. I mean, surgery, what I love about my field of surgery is almost everything I do. I mean, the majority of what I do is elective. I mean, surgery is never, in the hip and knee replacement world, it's never something that generally has to be done. And so we always start out with the options, which generally is first always non-operative. And, I always really go over the options with the patient in terms of whether it's surgical or non-surgical. When it comes to the surgical option, it's totally up to the patient. It's hard for me to recommend or say that a surgery has to be performed. And a lot of times the patients ask me, like, well, when do I need a hip or knee replacement? And I think that's a hard thing for me to answer, because I don't know what it's like to live with that sort of pain. Maybe I will one day, but I don't know what it's like to have arthritis. But I know a lot of people suffer from it and they have pain. And we always guide the patients and tell them that they'll know when the time is right when they need surgery. And somehow they do. It's almost like a sixth sense that, once they get to the point of their life where they just can't go on like that, that's when the time's right for surgery. And obviously based off their x-ray too, if they have severe arthritis and, they've lost all the cartilage in their joint and they're bone on bone, then that's obviously a pretty strong indicator that they're going to do well with surgery. But the option ultimately is always up to the patient in terms of which route they want to go. So.
Okay. And so I feel like I'm hearing you say that, you're there to consult and guide more than like push it. So just so everyone knows that, like, if you're worried about, like, if I talk to this, whether it's you or anyone, if I talk to this guy or girl, like, are they going to try to make me do it? It sounds like no, like, we're here to give you your options, and then it's up to the patient to decide what to do from there.
Absolutely. I mean, that would be my recommendation to anyone listening to this, is never, when it comes to this sort of surgery, I certainly hope that whoever you're seeing doesn't pressure you into feeling like it's something that needs to be done, but we'll lay out the options. And a lot of times surgery is a great option. I think it's what makes our field of medicine so special is we're able to do some procedures that really can improve people's quality of life. But it ultimately, should feel like you as the patient are making that decision along with the guidance of your provider and surgeon.
So what's involved in a consultation? Let's say I'm in pain, maybe I've been putting it off, but I decide, all right, you know what, I'm going to talk to somebody. Like, what's involved in a consultation?
Yeah, I mean, generally at our office, what'll happen is you'll come in and you'll meet one of our nurses or roomers will come in the room first, and they'll kind of get a basic history of what symptoms you've had, what have you done for it, who have you seen, if you've had previous surgery, what was done, when was it done, and then we'll generally get an x-ray, which is a huge part of kind of our arsenal of treatment, obviously, into seeing really what's going on at the joint. And then I'll kind of review the history, and I will look at your x-ray and then come in and see and examine you and kind of go through that same process, go over what you've done, what pain you've been experiencing. If you've had previous surgery in the past, what was done, if you're having issues with, your hip or knee replacement, we'll kind of go over what those issues are. And then depending on kind of what I see on the x-ray and based off your history and exam, that'll ultimately determine kind of my thought process. And certainly there are instances where I see patients and I can tell they're miserable, and if they have something particularly going on with their hip or knee replacement, there's certainly something that I feel strongly I can help them with. I would lay out the surgical options, and then we kind of tackle it from there in terms of what the patient would like to do. So.
Okay. And let's say, you've met with someone and everyone agrees surgery is the way to go. How do you start preparing? Is there like exercises you can do? Is there dietary changes? Like, what do you recommend? What's the plan to lay out to prep?
Yeah, it's good question. In prepping for surgery, I mean, it is in hip and knee replacement, it's a big surgery. We don't want to downplay it. We're, open up the joint. We're putting in metal and plastic, foreign materials into your body. But it has dramatic, improvements in your quality of life for those right patients. So there's a lot of preparing for it, kind of both around your house, making sure that after surgery you have kind of, the appropriate social support at home that can probably help you the first couple of weeks after surgery. We, especially pre-COVID era, we had a joint replacement class where everyone actually went and met with one of our educators at the hospital to teach them what to expect before, during, and after surgery. And right now we're doing that more virtual right now, but hopefully we'll get back to the in-person aspect of that. And then we generally do have you meet with a physical therapist at least once before surgery. And that's more so to kind of get an idea of what to expect after surgery, especially with knee replacement. A huge part of the success of your knee replacement is the rehabilitation aspect of it. So I'd say, obviously you need to execute a good surgery and good knee replacement, but it's very important to get back your strength and range of motion afterwards. We usually have you meet with the therapist once before, and they'll give you some exercises to kind of keep your motion and get it going beforehand, but they'll also kind of lay out the grounds of what to expect afterwards. So really a lot of it is planning for what it's going to be like after surgery. And there's no particular really exercise that I think is super important to do before, because at the end of the day, arthritis in your joint is more of an anatomic problem. The problem is that you've lost cartilage that's normally there between the bones. And, there's no exercises that you can do that's going to rebuild that cartilage, but the therapy afterwards is a very important aspect of what we do, especially more on the knee side of things.
Okay. And I definitely want to get to post-surgery, but I guess so now I was thinking maybe there would be more exercise going in, but it sounds like it's more like setting up your lifestyle, knowing you're going to be just limited physically. That's probably the biggest prep, and making sure, like you
Yeah,
said, a support system is there.
exactly. Yep.
Um,
That's
and
right.
then knowing obviously if people are in pain and they're not able to exercise in many cases, I'm assuming you see people who have put on weight. Um, how does being overweight, or if there's maybe cases of obesity, does that change anything, or is the process the same?
Yeah, no, it's a good question. So I think a lot of it comes in what you're referring to in selecting the right patient for surgery, because this surgery, and I know we're going to get into this later too, but these surgeries aren't without risks. And I think some of the biggest risks that occur with the surgery are a lot of times related to host factors that play into it. So some of the biggest risk factors in joint replacement surgery are obesity, diabetes, smoking, autoimmune diseases. These are things that we consider modifiable, so things that can be improved prior to surgery. And obesity is a big one. So, I mean, as you alluded to, we're facing an obesity epidemic. There's so much that plays into that, and I'm a huge believer in really a holistic approach to medicine, and I tell my patients, and I try and educate them on the importance of diet. And especially in the last several years, I've been educated myself on what the benefits of a whole food plant-based diet, and it's unfortunate that we're not, as doctors, educated on that more, because there's an incredible amount of research out there that a lot of the ailments we treat in Western medicine are related to the foods we eat, and a lot of that being processed animal-based products. And so sticking more to like a whole foods plant-based diet is obviously beneficial for a lot of people trying to lose weight and get into healthy lifestyle for this sort of surgery. But I see, a lot of patients that are BMI over 40, your risk of this surgery goes up dramatically, and the big one being risk of infection. So, it's a lot of times a longer consultation, a little more heart to heart, and trying to get on the same page with the patient to try and really optimize people for the surgery, because there's a great chance we could go forward and do the surgery and have success with it. But with the higher risks being facing with whether it be diabetes, obesity, or smoking, if a patient runs into that risk of infection, it's a huge thing to treat for especially the patient and for the provider and the patient as a whole. So a lot of times with the BMI over 40, we work really hard to try and get that under 40 with means of whether it be diet, exercise, consulting an operative or non-operative medical provider who specializes in that. But I always try and reach the goal of getting the patient's BMI under 40 if possible. And if it gets to the point where they're struggling with that and they can't get there, and they've tried and they've really done everything they can, then sometimes we cross that discussion of moving forward with the surgery despite having some of those factors. But those are things that I feel strongly are optimizable prior to surgery, and I do put some of the ownership on the patient to kind of work with me to try and get there. And most people are really, most people want to. And I got to tell you that the patients that have that motivation and have that success at losing weight, those are the happiest ones. I mean, because then not only do they have a new joint, but they've modified their lifestyle, they're living healthier, they've lost weight, and they're feeling better, and their outcomes better because of it. So it is something we face hand in hand a lot, at the obesity and the bad joint at the same time. But we kind of try and tackle both before proceeding with the
Okay, so less exercise and probably more diet. And I can imagine, like, if you're overweight, you're in pain, you probably don't, you don't feel good, you probably maybe mentally aren't in the best place. So it sounds like some dietary changes can really spur the change that people are looking for, and then the surgery is just the next step, but it starts maybe with the diet.
I think so. I really do.
Yeah. All right. So regarding surgery, how long do these operations take? Like, how long are you actually working on the patient?
So everyone varies. I mean, not all joints are the same. I'd say the majority of them take about an hour to do, whether it be a hip or knee replacement. Most of the surgeries take about an hour. Obviously, for patients with advanced arthritis, or if they have more complex cases, they can take longer than that. But most cases take about an hour. The patient generally expects to stay in the hospital one night. I'd say 80 or 90% of our patients are able to get home the next day. We get you up walking right away. We try and mobilize you as quick as we can. There certainly are some instances where if you're having pain control issues or having troubles getting up and moving around, that will keep you in the hospital 2 or 3 nights or whatever it takes. But I'd say the vast majority of patients can expect to try and get home the next day. And then I always try and counsel patients, especially in knee replacement. The first 2 or 3 weeks after surgery can be painful. A lot of times that pain, especially after a knee replacement, the first 2 weeks is more so than what it was going into the surgery. But at about that 2 or 3 week mark is when most people start to make the turn and most people start to see the improvement in doing the surgery. And by 6 weeks is when I see most patients are really satisfied that they had the hip or knee replacement done. And I usually say it's about 3 months kind of for full recovery from either of these procedures. So.
Okay, that's good to know going in just for planning purposes. How long, do you have like an average lifespan of like how long a knee should last or how long a hip should last, assuming, the patient's exercising, doing their rehab, taking care of themselves, dietary wise? Like, do you have how long should a knee and a hip last basically?
Yeah, those are good questions. So I think, obviously the reports we have on hip and knee replacement now are from 15, 20 years ago out. And, the majority of those, especially on the hip side, may last slightly longer, but I'd say at most reports between 15 and 20 years, the implants that were put in are still working well at about 85 to 90%. So I'd say in general, at about 15 to 20 years out, you could expect somewhere between a 10 to 15% rate of patients undergoing like a revision or a redo surgery. And that can be due to a vast number of reasons. Some of those are as simple as going in and changing out the plastic liner between the metal parts, and some of those could be more extensive. But I think with the newer implants, I would expect the longevity of those to last even longer. I mean, I think the engineers who have designed, especially the plastic, has made improvements in that, so they wear at a much slower rate. So I would expect the implants that we put in today to hopefully last even longer than that. And there's also been newer developments, and I know we're going to get into it a little bit, but in the cementing technique and also in some implants that are cementless that are allowing implants to last longer as well. That being said, it's still, it's still one of those things that we generally recommend trying to wait for younger patients, trying to wait a little bit longer if you can, just so that way you're less likely to need a revision down the road. But the same thing goes for patients in their 30s and 40s. If patients have horrible arthritis in their joint in that age and they've done everything non-op, then we're starting to treat those patients at younger age. And a lot of that's due to better implants that we're able to put in.
Okay. Yeah. Let's talk about that a little bit. So what are some of the changes that you've seen, whether it's cementing or even just the materials used? Like, can you elaborate a little bit on some of the changes that have been made recently and you're seeing more success with, or maybe longer longevity?
Yeah. So in the hip side, so, one of the kind of the forefather of hip replacement surgery, Dr. Charnley, he cemented his hips initially, and they had great success. I mean, even long out, they did really well. But we've now developed cementless components in the hip, where basically your bone grows to the metal parts. So on both the socket on the femoral side, your bone grows to that. In the long term, that's a benefit, because cement is strongest initially when you put it in, but over time that can loosen and wear out. And so on the knee side, we typically always cement our components in. But again, with the concern there is that if we're doing knee replacements on people in their 40s, that, by the time they reach their 60s, they may loosen. So there's been a lot of development by companies to make cementless implants with the same design, where basically your bone grows to it. And so it actually gets stronger over time as your bone grows into it. So I think on the knee side, that's been the big improvement, as we're starting to use some cementless products. We're also, as I've mentioned, the design of the plastic wears at a much lower rate. So hips and knees that were put in, 30 years ago, the plastic wore out and a lot of the bone around it eroded away. And the newer plastic doesn't have that issue as much. So not only are we not wearing through the plastic as quickly, but we're not losing bone around it. And for that reason, the implants are lasting a lot longer. So I think there's a lot of positive things that have happened on the implant manufacturer side of things that have certainly improving the outcomes of our patients. So
that's great. Gotta love modern medicine.
Yeah.
So Okay, post-op. We've talked about a lot of the benefits and a lot of the things that can go right. And we touched on it a little, but let's talk a little bit about some of the risks, because obviously we don't want to make it sound like it's all sunshine and roses. There
Right.
are risks involved with this. It's very, it's invasive, it's serious.
Mhm.
Um, what are some of the common issues that you see? Like, what are the most common problems you see?
Yeah. So you're right, and I think, gosh, I think we're really lucky now with practice. A lot of places has gotten to the point where surgeons have really found their niche, especially in orthopedics. We now are a lot of us are subspecialized, and I'm fortunate to just do hip and knee replacement. I have partners who just do ACL and shoulders. I have other partners who just fix fractures, and I think that goes a long way for the patients because the complications of each of those procedures goes down as their surgeon gets very subspecialized in what they're doing. So, I mean, we're fortunate that while this is a big surgery that carries big risks with it, I think the complications have gone down because of that subspecializing in the field. But as I touched on earlier, I think the biggest one we still see is infection. And infection of a total joint it's really hard to explain to the patient, but it's such a serious consequence because a lot of times it means we have to take the implants out. So for patients who get an infection, sometimes we have to go back in, take the metal out, put in some cement that eludes antibiotics, and they get an IV PICC line for 6 weeks with antibiotics in it, and basically are without a joint for up to 3 months. So that's probably the most common and serious one we see. For standard joint replacement in the literature, that's cited to occur at a rate between 1% to 2%. So it's, it sounds small, but you think 1 in 100, that's still like a high number.
Yeah.
We're fortunate to, I think our group's fortunate. Our rate is lower than that. And I don't know if it's just because a lot of it comes to, we obviously try and select our patients wisely and have good protocols to prevent infection, but we certainly treat infection that's sometimes sent to us from outside the community too. And the most serious consequence that I've seen is patients lose their legs because of it. It's very rare, but for infections of knees that have failed multiple surgeries and can't get cleared, then sometimes patients do wind up with an above knee amputation. So a very serious consequence, a very dismal outcome that fortunately is very rare, but I'd say that's kind of the extreme of the consequences that we see when it comes to.
And it's good to know that going in, obviously, like you said, regardless of how rare it is, people need to know,
Mm-hmm.
what they're signing up for and what the risks are just for everyone involved.
Yep.
So regarding infection, if I heard you correctly, you were saying that risk goes up with a BMI over 40%.
Yeah, over 40. Yeah. So I'd say for the standard rate cited is between 1% to 2%. Once you get BMI over 40, you're looking upwards of 5%, which is dramatically higher. And so it's kind of on a continuum as and I think BMI is just a marker of, I think, general health. And when your BMI goes up, the big reason for the infection rate going up is your immune system response goes down. So every kind of point you're going up in BMI, your immune system's suppressed to a greater degree. So, getting the BMI under 40 is great, but I always encourage patients, like, let's not stop there. Like if you're going down and you're getting healthier, like every point you go down is going to decrease that risk even more. So it's kind of on a continuum, and the lower we get it, the less the risk of infection goes.
Is there anything else a patient can do aside from like diet and just keeping your BMI down? Is there anything else they can do to prevent infection?
So, I mean, I think diet and health in general is the biggest thing. So anything they can do to make their overall health status improved, which, certainly comes from diet and exercise, and mental and emotional health is such an important part of this too. I mean, there's been great studies recently that show that patients, with, either depression or anxiety, like those factors, the outcomes with those aren't, do impact your outcome with surgery. So really doing everything in your life to help your overall health and every state of mind, whether it be mental, emotionally, physically, all those things will help improve your outcome for surgery. That being said, like having a pain-free joint is going to help all those things too. So it's a balance, you know what I mean?
Yeah.
That's, I think, what makes my job tough at times, is trying to balance the risks of surgery with the benefits of potentially helping someone by improving their quality of life with the surgery itself. So
Okay. Okay. And then, so I'm assuming you are prescribing pain medication. That's a touchy subject right now in our country. Um, is that something that you specifically do? This is kind of my ignorance here. Is that like, do you prescribe the pain medication, or like, is there a type that you recommend? And also to take that a step further, like, how are you guys trying to help people with opioid dependency and making sure it doesn't become a problem?
Yeah, no, thank you for asking that. It's a good question. And the so we try and get, if patients are on opioids before surgery, we try and get them off it if possible. And the big reason for that is if you're on opioids, your nerves are kind of numb to pain, and then we do a big surgery on you, and your pain response kind of shoots through the roof. So if possible, we try and get them down as much as possible, or decrease the opioid consumption before surgery to help with pain control afterwards. Typically, if someone's on long-term opioids, we try and either coordinate with their pain management specialist who prescribes them to help control pain after surgery, because a lot of times that may require higher narcotic use than what we're used to giving. But for patients who don't take narcotics preoperatively, then I'd usually be the one to prescribe it, or the surgeon would be the one to prescribe it after surgery. And it is, as I touched on, it's a painful surgery. So for most patients, you do need narcotics for about a week or two after surgery. And some patients really don't want to take them, and I admire them for wanting to avoid getting addicted. But I also counsel them that, like, don't try and be a hero. Like, you're probably going to need it for several days or potentially a couple of weeks. And based off their mentality prior to surgery, if they're thinking that way, they're going to have no problem getting off it. But I think it is more an issue for people who are on narcotics preoperatively, trying to control pain after surgery. And that's where, as I said, we just try and get the pain management specialists involved, so that we make sure we can try and control the pain the best we can after surgery.
Okay. Yeah, I'm sure it's a touchy thing. It's like, you want to help people and you don't want them to be in pain, but you also know, in the same way that surgery is a risk, there's also a risk in the pain management. So I feel like you said, it's more of a holistic approach, and just monitoring and probably keeping in touch and making sure you know what's going on with them.
Yeah, and I'd say, and for some patients too, I think the patients that sometimes come in on high dose narcotics, those may be the patients that have really bad joints too. You know what I mean? Like, there's a reason a lot of times they're on those sort of pain medicines. So, by the time you replace the joint and take care of the problem, a lot of times one of the great success is seeing them get off those medications, which is
Oh,
really
that's awesome. Good, good. Okay. So kind of transitioning into the rehab. I know we've talked about it a little bit. Um, I was going to ask how long rehab takes, but it sounds like, about 3 months. Is that correct, or is it longer? Like, what's rehab like post-op?
Yeah, so usually, so generally on the hip side, we don't do formal physical therapy. Actually, just getting up and walking is kind of the best therapy. And the main reason for that is the hip is actually, the hip stability after a total hip replacement is kind of the bigger concern. And sometimes overdoing it or stressing the joint too much can affect the healing process. So we usually just want patients getting up and walking as much as they can, and that actually gets the muscles around the hip joint strong, and it also helps prevent blood clots. For knee replacement, though, physical therapy is very important because the knee tends to get very stiff. So one of the biggest things that the therapists do is they work on motion, getting the knee straight and getting the bending back. So generally, you're doing physical therapy outpatient with a therapist for 2 to 3 times a week, somewhere between 6 to 8 weeks. For patients who are maybe having troubles getting their motion back, they may go a little bit longer than that. But I'd say for most patients at 6 weeks, they've gotten their motion back. They're able to do the exercises on their own at home. And that's really where the money is. The therapist will work with them a couple times a week, but the most important aspect is really going home and doing the exercises they prescribe for them on a regular basis. Generally, that's about 30 minutes a day, broken up into about 15-minute sessions. So twice a day for about 15 minutes, they're working on some sort of strengthening or motion in the knee. And they should be doing that every day for the first 6 to 8 weeks after surgery.
Okay. And I know just from, watching my parents go through it, like, my parents are pretty tough, and they were telling me it hurts like heck.
Yeah.
How much pain can they expect during the rehab process? Like, especially, I don't know if there's a difference between hip and knee, but if you want to
Yeah.
touch on kind of the pain during
Yeah.
knee.
I mean, it's a good point. It's on the knee side of things, those first 2 to 3 weeks, you can expect the pain scores in rehab to be reaching, 7 to 8 out of 10 for most people. So a lot of times we make sure that they're taking their narcotics or narcotic pill before the rehab session, because that therapist is going to go in there, manipulate the knee, and try and get good motion out of it. And so those therapy sessions tend to, patients come to the clinic and say, my therapist really worked me. That's a good thing. That's an important part of reaching a good outcome from the surgery. But for those first 2 to 3 weeks, they can expect a moderate amount of pain with physical therapy. Most patients, tolerate it well, but they go into understanding that there's going to be some pain associated with it. But by the time they see you at 6 weeks, they're usually very happy that they took on that pain and got to the outcome that they're at. So
Sure. Kind of begin with the end in mind.
yeah.
So what happens if you don't stick to the rehab program? Like, what are the risks if you just can't do it, you won't do it, you don't do it? Like what happens if that doesn't follow through?
So especially on the knee side, again, the knee can get stiff. So basically if you don't move it, because it's painful to move at first because you've done the surgery, there's some bleeding involved in the joint. With that bleeding forms scar tissue. So if you're not moving the joint to mobilize and to break up that scar tissue, the knee starts to get stiff. And so sometimes in those instances, what we wind up having to do is, sometimes between 6 to 12 weeks after surgery, we take the patient back to the operating room to do what's called a manipulation, where we actually physically put the patient to sleep and bend the knee and try and straighten it to break up all that scar tissue. And, that is overall like a less invasive procedure. We don't make an incision. We basically just kind of manipulate the knee to break it up, but it's something we obviously really want to avoid. We want to avoid ever having to take the patient back to the operating room. And then you're not starting back at square one after that, but in some ways you are, because you've just broken up the scar tissue, and then you got to get back in the rehab and really do the process all over again so that it doesn't reform. So the consequence of not doing the therapy, which is a very important part of the surgery, would be getting a stiff knee. And then ultimately your outcome of stiff knee is much less optimal than someone who has full motion of their knee.
Kind of probably defeats the purpose in the first place.
It can, yeah.
Okay. And then, so kind of shifting to something a little more contemporary with COVID, what precautions are you guys taking to prevent the spread of COVID?
Yeah, so this has been an evolving process, as you can imagine. So, when we first started, so obviously when COVID hit last, March and April, we shut everything down. We weren't doing surgeries. We were still seeing patients in clinic who needed to be seen, but we only did absolute emergent cases. Once we were able to get back up and running, that's been obviously a good thing for everyone, but especially for the patients, because a lot of these patients were living a couple months needing surgery, wanting surgery. And so it's been good. We got to get back up and running. Initially, we were making it so that only the patient was coming into the office or coming into the hospital for the surgery. We weren't allowing guests. We're still at that point. So when we see patients in clinic and in the hospital, we're still at the point where no one can come back with the patient aside from the patient to help minimize the spread. Of course, we're having everyone requiring masks while in the office. We're now at the point where we're testing every patient before they come in for COVID. So they're getting a rapid test just to make sure they don't have COVID, A, so that they're not spreading it, but B, so that if they are sick, we don't want to, double down and put the stress of surgery on top of their body already trying to fight the infection. So those are kind of the main things that we've kind of progressed to doing. So we're obviously taking it very serious. But we're encouraging all our patients to get the vaccine. And our only restriction right now is we're trying to avoid the vaccine within 3 days of surgery, just because we don't want any fevers that may occur after the vaccine to be thrown off by fevers that could occur around the time of surgery. But based off the fact that we don't have a lot of research to go off of, we don't want to hold people up from getting the vaccine. So we're encouraging people to move forward with vaccination if they're able to at this point. So.
Okay. And then should someone who's high risk postpone surgery? And I know you talked about it being, with surgery, it's elective, so it's obviously up to them. But if somebody knows they're high risk, whether it's autoimmune or I don't know what all the reasons would be, but if someone's high risk, do you recommend postponing, or does that not matter?
I think your question is much more relevant now that the vaccine is out and available. And ultimately, that's a question that I think I would counsel the patient on ultimately considering for their own sake. I think we've certainly had a lot of patients that would have been considered high risk that came in and they've successfully had their surgery and gotten out okay. But that's not to say that someone, may not come in and have COVID and then have a poor outcome. So ultimately, I think that's something that is an important discussion between the surgeon and the patient to weigh the risks and benefits there. Now that the vaccine's available, I think for patients who are super high risk and are very concerned about the virus, I think it's reasonable to get the vaccine first and then consider, the surgery after they're appropriately vaccinated. But I think patients who are miserable with their pain and are, want to move forward with the risk of getting the surgery, I think that's very reasonable as well. But I think ultimately it's kind of the important discussion between the patient and surgeon to arrive at the right conclusion based off, a patient's particular case.
Sure. Well, I mean, that's pretty much, I think we covered kind of the gambit there. That was awesome. I like to end every interview with the same question. So what's your favorite thing about living in Fort Wayne?
Yeah, well, so this has been great for me. I grew up in Fort Wayne, and now I've been away for 14 years doing education and training, and I've had the fun of going and living in other cities. But it has been so great to come home and be really, I think, around just friends and family. But I also forgot just how really good of a town and nice a town it is to live in. And I think it's the community. I think it's the community aspect, the people in the town, and the population that we serve. I mean, I love waking up each and every day and going to work and the service I provide. And I think a lot of that has to do with the people that we serve and the people that maybe have hip and knee problems, but they want to get better and they come and ask them for help. And then the gratitude they have after a successful operation is it's a more rewarding career than I think I could have ever hoped for or expected. But doing it in Fort Wayne, I think has been a huge part of that because of the community here. And so I've been, very happy to be back in the community, and I'm excited to hopefully live the rest of my life in town.
That's great. That's exactly, I mean, as many people know, I left and came back, and pretty much what you said, I've had the exact same experience. So it's cool hearing other people say that. So,
Yeah.
How can people learn more about you? Let's say someone does want to connect with you and maybe ask you some questions. What's the best way to get a hold of you?
Yeah, no, I appreciate you asking that. So I work at Ortho Northeast O&E. So I think if you go to our website, I know we have some presence on Facebook and social media, and also if you Google Ortho Northeast and head to our webpage, my bio information's there. There's a number to call to make an appointment, and whatever ortho needs you have, I certainly, my entire group is happy to try and help people who may have aches and pains in their joints or arms or legs. And we're there. That's what we're there for. And that's why we love serving the community. So.
Well, this has been great, man. And one of the reasons I picked you and wanted to do this period is I feel like sometimes medical professionals, specifically doctors, get a bad rap. And I think the underlying theme that we've heard today is like how much you care. I mean, everything you said is like putting yourself in the patient's shoes or thinking about what's best for the patient. And I think that's been very clear today. So I hope everyone else picked up on that like I did. And I really appreciate you joining us, and thank you for your time.
Yeah, thank you, Jake. It was great to be on, man.
All right, I'll see you on the golf course soon, hopefully.
Sounds good. All right, man. See ya.
See ya.